or evening, depending where are you joining us from. Welcome to this webinar of the series Mental Health for All, a series of webinars that already for 2 years now has been bringing us together around very important topics related to global mental health. And a series of webinars that today is going to give us the opportunity to get to know the latest report from WHO on one scientific brief on COVID-19 and mental health that I think is going to be extremely interesting for all of you joining us today. We welcome you to this webinar. We encourage you to share your questions through the chat box as we move forward. And I would like to start by introducing myself. My name is Carmen Valle, and I am the co-chair of the Interagency Standing Committee MHPSS, Mental Health and Psychosocial Support in Emergencies Reference Group. I work for the Psychosocial Center of Reference at the IFRC, and I'm going to be just chairing today's session, having a very interactive and interesting one, and being joined by some excellent colleagues that many of you already know very well, and that we are very, very happy to have here today. So thank you everyone for joining us. I would really like to, first of all, allow you to introduce yourself. So if I may pass over to Marit first, as you will be our first speaker. Over to you.
Yes, thanks a lot, Carmen, and thanks very much for inviting me. I'm Marit Sibrandi, and I'm a professor of clinical psychology at the VU University Amsterdam, and also a co-director of the WHO Collaborating Center at that university in the Netherlands.
Welcome. Thank you for joining us today. We're looking forward to hear your presentation. We also are joined by Mark van Ommeren from the World Health Organization. Over to you, Mark.
Yes, hello everybody. My name is Mark van Ommeren, and I am the unit head in the mental health unit in the Department of Mental Health and Substance Use at WHO in Geneva. Happy to be here.
Lovely having you, and thank you for joining us as well. We are also being joined by Brigitte. I'm not sure if I can say Kuri.
Yes, very good. Thank you. Yes, I'm Brigitte Kuri. I'm a clinical psychologist at the Department of Psychiatry at the American University of Beirut in Lebanon. And it's an honor to be among this panel. Thank you.
Thank you. It is an honor to have you as well. Thank you for joining us and making the time. And last but not least, we have our colleague Judy Kariuki. Over to you, Judy.
Hi, everyone. I am Judy Kariuki. I implement mental health projects in Kenya in my capacity as a project officer for mental health and well-being. My background is in clinical medicine and surgery, and I have years of experience in program management. Thank you.
Thank you so much. It's wonderful to have you, Judy. Really good to hear back from our colleagues from Basic Needs. Wonderful. So let's jump into it. We have a wonderful new scientific brief, and the first thing to be able to talk about it is to know about this content. So I'm going to pass over to Marit to be all of us enjoy this presentation about the content of the brief. Over to you, Marit.
Thank you very much. Assuming you can see my screen. Yes, correct. Okay, so thanks a lot for the invitation. And I'm very happy to present here the results of a scientific brief that we wrote together here at VU University, Department of Clinical Neuro and Developmental Psychology. We did that with a lot of colleagues because it was a big effort to do, a lot of work. We needed a lot of people being involved, colleagues from the Vrije Universiteit, but also colleagues from the University of Verona in Italy, INSERM, Paris, France, and the University of Madrid in Spain. Also colleagues from Swansea University and the University of Bristol in the UK. And of course, also we had great help of our colleagues of the WHO Department of Mental Health and Substance Use. Already since the start of the pandemic, late 2019, early 2020, a number of people in the population were identified as potential risk groups for being affected by the adverse mental health consequences of the pandemic. And of course, the whole population has been affected by the pandemic. We all were afraid of being infected by COVID. We had to adhere to regulations to contain the epidemic, and that took a very long time. But in addition to the general population, there were also some risk groups early identified in the pandemic that were potentially at a higher risk for adverse mental health consequences. And these risk groups, for instance, were people who underwent a very severe COVID-19 infection, and later stages during the pandemic, also people with post-COVID-19 conditions have been identified. People at risk for COVID-19 or a severe course of COVID-19 were older adults, people with pre-existing health conditions. Also, there were concerns about people with specific mental disorders, children and young adults who were affected also by school closures, by closing of higher education, but also by restricting social activities. People living already under precarious circumstances, and people in humanitarian and conflict settings. We wrote this scientific brief where we focused this on a number of specific questions. First of all, we were interested to see whether or not the COVID-19 pandemic, what the effect was on the prevalence of mental health symptoms and mental disorders in the general population, but also in the risk groups I just mentioned. We were also interested to see what the impact would be on the prevalence of suicidal thoughts and behaviors. Specifically in terms of people already living with mental disorders, we were interested to examine whether they were at an increased risk for infection, for severe illness or death from COVID-19. And because of the COVID-19 pandemic had a very strong effect on the accessibility of mental health services, and there was also some disruptions in mental health services, we were interested to see how mental health institutions mitigated these disruptions. And finally, we were interested to see what the effectiveness was of psychological interventions specifically adapted to the COVID-19 pandemic in order to prevent or reduce mental health problems or to maintain access to mental health services. So the sources of evidence we accessed in order to examine these questions were, first of all, the Global Burden of Disease study that was published in the autumn of 2021. That was a study that integrated all the numbers of 2020, the Global Burden of Disease prevalence rates worldwide. We performed an umbrella review of systematic reviews and meta-analysis up to October 2021, and the specific search strings and also the search terms were published in a protocol that can be accessed on the Open Science Framework. We also had an access to a living systematic review performed by colleagues in the UK on COVID-19 and suicide up to September 2021. And finally, in terms of looking at mental health services access, we also included a relevant WHO reports. So in terms of what we found in relation to COVID-19 and mental disorders, we did find, based on the Global Burden of Disease studies, we did find a significant increase worldwide in mental health problems in the general population during the first year of the pandemic. For major depression, we saw an increase of almost 28% in the global population, whereas for anxiety disorders, this was 25%, 26%. And of course, this has also led to an increase in disability-adjusted life years, so for major depression, but also for anxiety disorders. We also did an umbrella review, so we collated evidence from systematic reviews and meta-analysis, which largely confirmed these findings of increases in the mental health problems. Looking at risk groups, we considered a number of risk groups. I just explained before, but in terms of the evidence, we were mainly able to find evidence for young people to be at a higher risk for mental health problems related to the pandemic, females and people with pre-existing health conditions. However, the data were mixed in terms of these risk groups, and we did not find any convincing evidence, for instance, for healthcare workers. as a specific risk group. However, it's important also to consider the limitations of studies. We did have a great lack of longitudinal studies with a pre-pandemic assessment, which is of course needed to draw any firm conclusions related to increases in mental health symptoms. And there were also a lack of studies in specific populations, for instance, people with post-COVID conditions, refugees and migrants, or people in psychiatric institutions. There was no clear evidence for increased suicide rates in most countries since the pandemic began. However, young people were at a higher risk for suicidal behaviors, which was of course very concerning. There were no changes in or fewer hospital presentations for self-harm, which may reflect actually a lack of access to these services in the first period of the pandemic. And we also found that exhaustion, loneliness, and positive COVID-19 diagnosis increased the risk for suicidal thoughts. Again, these studies were limited by a lack of studies in low middle income countries, and study of suicidal thoughts were mainly based on internet surveys or non-representative samples. And of course, if we look at the studies that were done using the mortality statistics of suicides, there is always a delay in reporting. So probably we will need to await more results actually to be published the next months. In terms of people with pre-existing mental disorders, we were able to find quite consistent evidence that they are a distinct COVID-19 risk group. They had a greater risk for severe illness once they had been infected by COVID-19, or death related to COVID-19, so higher mortality. And this was even more so among young people and people with severe mental disorders. However, there was no consistent evidence for a greater infection risk among psychiatric patients. However, these studies are also limited by the fact that they're mostly case control studies or cohort studies, and very few prospective studies included. And of course, the COVID pandemic had a very strong effect on how outpatient mental health services were delivered. So a lot of services have been inaccessible for a period of time, and that depended on the context, it depended on the country. But in general, there is evidence that outpatient mental health services were very often disrupted during the pandemic. And this was specifically the case for school mental health services and also for alcohol prevention services. And some institutions partly mitigated these disruptions by moving rapidly towards e-mental health services, which is of course a very, one of the positive effects of that. However, it's also very important to realize that there are very strong barriers in accessing e-mental health services. For instance, some people have very low levels of technological literacy, certain population groups. There's of course privacy issues. Some people don't have access to private e-mental health tools. For instance, they have to share phones. They have no opportunity to do that in privacy. Providers may not feel at ease with offering e-mental health services. And also in a lot of countries and a lot of situations, there is a lack of digital infrastructure or a very poor internet connection. Again, we noticed that in general, the reviews on this topic were not of high quality, and most of the conclusions regarding the efficacy of these mental health shifts were mostly based on qualitative studies and not on quantitative studies. If we look at the effects of mental health services that during the pandemic were specifically adapted to the pandemic, in general, we see a lack of studies, because of course it's very difficult to do an RCT, a randomized controlled trial, very quickly after the pandemic began. And actually these studies are now going to be published. We also know that there are, fortunately, evidence-based effective interventions available for mental health disorders, even before the pandemic, of course. If we look at the interventions specifically adapted to address COVID-related distress, we found that psychological interventions were actually effective in reducing these mental health problems. However, The interventions that were included in these meta-analyses were very different from each other. So they're very heterogeneous. And there were no data available comparing interventions specifically adapted to COVID-19 versus interventions that were actually regular types of interventions that were used already for depression and anxiety, for instance. Yes, so I would also like to thank the steering committee that helped us with drafting this scientific brief. And I would like to thank you all for your attention. And I'll give back the word to Carmen.
Thank you so much, Mary. That was a wonderful presentation. Very, very interesting. Not that positive, but we were expecting these kind of results. We're going to gather a few questions around this report, and our dear colleagues are going to help us going through them. But again, also we'll have some time to Q&A. So if you have questions right now or throughout the conversation with our colleagues, please post them in the chat and we will ask them at the end. Mark, seeing this presentation, one can only think it is how needed it is to have this data. But we know that now. Why did WHO find it very important to have this brief done? Why did you commission it? And most importantly, what do you hope to be able to do with the results moving forward?
Now I'm unmuted. Okay, so thank you for the question. And of course, it was a great presentation you gave, Matt. Thank you so much. The reason, the background to this effort is when the pandemic quite quickly affected all of our lives and brought mental health concerns even higher on people's minds than they were before. We got a lot of requests on what to estimate with media, with partners, on what WHO thinks the impact would be of the pandemic, or what was the impact of the pandemic on mental health. Very difficult question. Particularly for me, it was particularly difficult because I did my doctorate studies on the epidemiology of mental health of populations affected by emergencies, refugees in that case. And from that, maybe I knew too much. But I was like, I knew that how difficult it was to give an answer that is one can have confidence in. So we actually didn't answer the question for quite a while directly. We referred to earlier work, to what it would likely be, but we didn't go deeply into it. But the pressure continued for good reason, because people need to answer to these questions. And the challenge of these studies is that the biggest challenge, which wasn't anticipated, what happened is the amount of science. There was probably no faculty of psychology, psychiatry, or social work in the world that started doing studies on COVID-19 and mental health. So there's initial articles from the beginning of the pandemic, and now already have 10,000 citations. It means 10,000 other articles have been written on this in 2 years. As far as I know, I've never heard of anything this volume of fast research output. But many of the studies, of course, are varying quality. Many of them use non-validated measures. Many of them don't use a baseline, because there was no baseline. And how can you cannot make up the baseline? Many of the studies used non-random samples, phone calls, all kinds of ways. And if you could look at all those different threats to validity, then one gets really concerned about whether the conclusion, and one puts everything together, is the right answer. And we've seen this earlier in the literature, meta-analysis on impact of mental health on refugees, for example. That you get really ranges of numbers and sometimes very strange findings and high findings. So we were very conservative, but eventually we need to do this. We need to get into this. Meanwhile, WHO, because the pandemic brought a lot of attention to WHO increased its quality assurance in its publications with a particular focus on COVID-19, with an extra layer of an independent review group that looked at every single publication to see that everything we said was science-based because we're so exposed to media. And we've set the standard of writing something on COVID-19 and health even very high. We already have my own concerns, might be my own, but WHO as an organization set it very, very high. And we decided that at the end we would do a formal scientific brief, formally commissioned, a request for proposal, to have an independent steering group by people who have a strong record in doing systematic reviews and independent assessments without any funding from industry or from any funny influencers. And we did this, and they did the job. There was a second reason why we did it, because also this year we will be releasing a World Mental Health Report for the first time in 20 years. It will come out likely the last week of June. Now, for that report, we want to write about COVID-19 and mental health, and we needed these facts because, again, it's about COVID-19. It's the highest quality. So we really needed this report to be done well. So I understand that the team of Marit and many different universities who collaborated on this, more than two collaborating centers were part of it, plus a number of other entities. They went through 45,000 citations just to come to these very straightforward, simple conclusions. But the efforts of this is often happens. You know, you have quite an obvious answer or not obvious, but simple answer to enormous effort. The effort for me, just to say that I think it was a great job. I think that was reassuring is that the suicide mortality rates globally have not risen, although there are some countries where it has, but most countries it hasn't, which is fantastic news. Concerning is that the numbers have gone up, of course, 25% is the estimate. That is a lot, but it's not as much as some media will tell you, where it was suggested that there's no resilience. A lot of people have shown resilience and are showing resilience. Most people have. But still, the rates, 25% more people are depressed and anxious than before, as the best estimate. These are initial estimates. That's why the title of the brief is initial estimates. But what's really concerning, of course, is that people with severe mental health conditions that exposed to COVID-19, that they are faring worse. They're not more likely to catch it, but once they got it, they're more likely to fall ill and suffer severe consequences. So that highlighting that really important point and having a solid scientific base for this, only that is already all worth the search of 45,000 citations.
Thank you so much, Mark. Very, very interesting answer. Also, very much looking forward for that mental health report. So we're looking forward to have it and read it. You were just at the end summarizing some of these again, the results that Marit was presenting, and I would like to ask Bridget, from your experience, from the work that you do, are these trends something that you can see happening as well? What do you see as trends in the impact of COVID-19 in the of the pandemic on mental health? And do you think these are the same trends that we're going to continue seeing? Do you already oversee changes? What is your personal and professional view on this?
Yes, thank you. Well, I mean, the universal trends that have been reported are mainly along the fear and anxiety and depression spectrum, which is actually what we see in our clinics. You know, people found themselves very vulnerable, unable to predict or plan their future, which is very difficult for us as humans. The suddenness of the pandemic and the disturbance it caused people in their everyday life so unexpectedly, as well as the lack of information or knowledge about COVID-19, made people realize how fragile they are, and hence increased very much the level of anxiety because there were so many unknowns. Now, of course, the social isolation, imposed through quarantines all over the world was a main factor actually to mental health problems. We are social beings, so being alone for days, weeks, without being in close proximity to anyone was very difficult on many, many people. In a way, I mean, there were reports that families or peers isolating together were better off mentally than individuals who were isolating alone. And, you know, it's understandable why that is the case, because if you have people with you all the time, of course, in certain situations where there's violence and abuse, that was actually very much a detrimental impact. But most of the time, it was better to be with family than being alone. That's why we saw a lot of people actually traveling before lockdowns to be with their families in different towns in different countries. And another issue was actually bereavement. It was seen that, especially with the loss of family members unexpectedly, and the traditional rituals that are usually performed all over the world were not being performed. There was no social support, no family support. People called, you know, to talk to each other. We are actually writing an article about this issue, that this could be a higher risk for complicated grief, the fact that family members lost someone to COVID-19 very suddenly and did not have the traditional support that exists in various cultures. Now, another aspect is that the youth, I think, were the most impacted. Their lives usually go around socializing with peers. Their plans were halted or delayed, especially those who are in university, going to study abroad, starting their work career. This age group of 18 to 25 increased exponentially in our clinics, which is usually not the highest age group we see. Yet they came, again, suffering with a lot of anxiety, panic attacks, depression, suicidal ideation, which is, again, something I think that was very much one of the results of COVID-19. Now, I think the psychological impact of the pandemic will last longer than the pandemic itself, unfortunately. We all know mental health issues, you know, take longer to resolve. And I think it will take time for people to trust again an undisturbed life and the ability to plan and live normally, whatever that means, without the measures that they have been taken for the past 2 years. And another issue that we're seeing now is the post-COVID impact on neuropsychology, on memory, on concentration. Now we're starting to talk about it. Again, more research needs to be done, but clearly there is an impact on post-COVID that people are still suffering from, and that we are starting to looking at it. So unfortunately, I mean, COVID might go away, but its impact, I think, is here to stay for a few years.
Thank you so much, Brigitte, and very, very clear answer, very important reflections on the impact of youth, for example, on those difficulties in grieving when our communities are closed. So going to the community, Judy, Basic Needs Kenya and Basic Needs in general really works very close to the community. It's a work with and from the community. I would like to ask you, if from your experience and the experience of those around you, what do you think? We've heard a few different things now in the webinar. What do you think is the biggest impact of the pandemic on mental health?
Okay, thank you so much for the question. Out of the many ways that Bridget has talked about, I would like to highlight the two impacts that I felt were very outstanding in my country and also among the people with lived experiences of mental health problems that I work with. The first one is information, which is actually also going on, especially because of the COVID vaccine, and also social isolation. So on misinformation, there was an uproar in my country following the decision to minimize movements, which was of course meant to slow down the spread of COVID, but also it came with other effects on people's health, jobs, and also the interaction between people. It led to a lot of people around me asking, and even in my country, about their human rights, especially when it came to the effect that translated into people having a lot of relapses among the people with lived experiences of mental health problems. We didn't have any chance for intervention, or very little chance for intervention. At Basic Needs, Basic Rights, we came up with a strategy that will help people understand their human rights through the WHO quality rights training, which also doubled that as a chance for the masses to learn about mental health, which will also contribute towards our goal to end stigma and discrimination. In addition, we took up social isolation and ran an intervention following the NHS 5 steps to mental well-being. In a period of 5 weeks, we picked different challenges per week, and using our social media and also through social media influences, we built a crowd and took the chance to encourage the public to connect with others by making scheduled calls to friends and family, creating family time, giving their expertise, time, and even material things to people who needed them. We also took a whole week of encouraging people to be active within their homes. We had a fitness instructor coming over on our social media pages and encouraging people to at least have an hour of exercise every day. We also had a whole week of mindfulness, where people had a yoga and meditation. So with every challenge that we ran for a week, we were asking people to take up a module in the quality rates course, and they reported their success. More than 300 people were able to participate in the challenge and also train and get a certificate. Thank you.
Thank you so much, Judy, and it's wonderful to see this level of activities that go so directly to colleagues with lived experience and those who are being impacted. So that brings me a little bit of the reflection. We write scientific papers. I'm going to go back to you, Mark. There's always a question around translation of scientific results to the community. So now that the brief has been published, what are the next steps that you're hoping to have in communicating the scientific aspects related to COVID-19 and mental health?
Thank you. Well, we will, I mean, first of all, we are very grateful to United to do this joint session, that this is a way of communicating to all of you, and I hope the people who are here will share further. There will, of course, the authors of the brief will be making articles. But we want to take this further, and we're not yet resourced to do this, but we do have a plan. And our plan is to update, because the thing is, the problem with evidence-based medicine is that everything takes time and things get outdated very quickly. So the 45,000 citations were reviewed by October, but now it's early March. So one can start the update already now in a way. The question is how there is such a thing in systematic reviews as live systematic review, living, and we could go in that direction potentially, but also very importantly to broaden the scope, because the number of questions that are answered are great, but the number of questions that are not answered are greater. And for example, I have a suspicion that there is issues not only with depression, anxiety, but also with eating disorders, also potentially with obsessive compulsive disorder, also no doubt that all kinds of behaviors like alcohol use, substance use, gaming, gambling, all of those are potentially affected, and there is lots of literature on that needs to be synthesized. There is, Brigitte was mentioning the issue of prolonged grief, or complicated grief, or different terms, but the WHO always say prolonged grief disorder. And certainly the effects of people who have developed this post-COVID condition, or many people call long COVID, that's not easy at all. And post-traumatic stress disorder, of course. So there is a lot of more to know and to update. But there's also not only on the positive, there's also positive things that may have happened that also should be monitored. For example, I think many of us suspect that towards certain mental health problems have reduced. Not towards all, we're not there, but some of it has reduced. The discussion on mental health is somewhat easier since many of us have experienced and are more comfortable, it seems to be, talk about mental health difficulties. I'm not sure whether that is just among certain segments of the population or whether that's population-wide. So there's a lot to find out. So there are many dilemmas to be many answers we still need. So we hope to be WHO will not be the organization that will do all the data collection on mental health and COVID-19, but WHO should be, and we aim to be, continue to be, the very solid source for member states for information such as this on to synthesize all the inconsistent evidence that's out there on mental health and related difficulties. Now, what it means, how we use it, World Mental Health Report, of course, we use it for advocacy, we use it to press with everybody, especially governments, to prioritize mental health services. I think most people who are in this network will agree that mental health has been neglected for too long, that we need to work together to advocate, to make sure that services that should have been in place with or without pandemic now certainly will be in place, and they have to be in place in the community. People need to have access to mental health care. It's not only about mental health care, it needs to also be protected from the risks of mental ill health, whether that is poverty or all the other risk factors that we know, determinants for poor mental health. So all of that, this information is important for all of that.
Indeed. Thank you so much, Mark. Absolutely. And those are already some of the key things that we need to be looking forward in terms of integrating better mental health response in COVID. But Bridget, maybe back to you and what would you hear in what's been discussed so far, and adding that own experience, what do you think should be the priority within the COVID-19 response and the recovery plans for mental health? What do we need to be looking into more urgently?
Yes, thank you. Well, I think one of the things that Mark touched on is that one of the good things of the pandemic is that it really puts mental health on the forefront, where it was unavoidable to talk about it because it impacted people on so many levels. So I think the priority when it comes to response is to really validate the mental health problems within the pandemic and recognizing that this is actually a part of the pandemic and what people are suffering from. I think it's important, of course, to include mental health services as an integral part of the medical services needed for individuals with COVID-19. For example, in our hospital, patients who were admitted to the hospital immediately were offered telemental health services where they were in the rooms with people from our department, on laptops, trying to support them, especially early on, and support their families, or people who were in quarantine for 2 weeks and didn't know what they were supposed to do. That's a very long time to be alone. And I remember early in the pandemic, we really knew nothing about it. So the mental health support was very important at that phase. And I think that really helped people bear the quarantine, bear being in the hospital, bear the sudden separation from the families suddenly looking through glass doors and windows to their loved ones who are in hospitals. So that was very important. I think we need to provide training for health workers and mental health workers to be ready to face such situations. There was a shortage everywhere in the world. And one thing maybe we didn't think about or we didn't know is that health personnel themselves were getting sick. So we had a shortage already of people who were trained, let alone people who were trained became ill. So we need to have a buffer to be able to provide relief for their colleagues. Now, one of the best things I think that happened is actually telemental health through this pandemic. It really became so important in order to have people were able to have accessibility to care through the telemental health. And luckily, we are in a field, mental health, where you can do it through online and virtually easily. You know, we don't need to examine patients physically or see things. And this is why, you know, I think mental health were among the first services to be offered as in telehealth. So reinforcing the growing importance of telemental health, training more people in it, advocating for it. I mean, even when the pandemic is more or less controlled, we still have people who don't want to come to our clinics and they want to stay receiving services in telemental health because it was much more suitable for them. One of the challenges we had is actually to have inpatient psychiatric services for COVID-19 infected people. And this was a category of patients that unfortunately we did not have the luxury of having separate psychiatric services. Most of them ended up being either on medical floors or stayed in the ER for days. So it was not ideal, but this is one thing that I'm not sure about many countries, but at least in Lebanon, and I know several countries in the region suffered from immensely whenever there was a psychiatric emergency with COVID-19 infection. I agree with Mark, governmental health policies always lag behind when it comes to mental health services. I think now there are so many evidence and focusing on the importance of having mental health as the main objective in the national program, working on prevention, intervention, and advocacy for these services. Now, 2 points that are particular to our region, and is that one of the things we need to recognize that pandemics occur on top of other disasters. And I can give you one of our examples. When we had the Beirut blast, which happened in August 2019, and the port exploded, and we had, you know, casualties, etc., etc. It was in the middle of the highest COVID numbers, and nobody could think of COVID at this point. People needed to be saved and taken to hospitals, and we have several hospitals that were demolished, actually. So services were provided, and with no thinking of COVID or taking any measures of safety, because there were more pressing things. I have the same idea when I see now on CNN or other news channels, when I see trains packed with Ukrainian individuals, packed, and I'm thinking, how are they doing for COVID, and how are they managing to make sure that COVID infections are controlled? But I think at this point, it doesn't matter, because it's more important to save one's life than to think of, you know, a pandemic and COVID, etc. Now, vulnerable groups that also Mark touched on are refugees. And during pandemics, somehow refugees and displaced groups are not a priority. A lot of times they do not have access to the regular normal services in the country. So they are really left behind. So it's very important to focus that relief efforts in pandemics are reaching this type of population because they are part of the community. And they can be reached through maybe not the regular services that are given nationally, but through NGOs and other community services that are offered to them. So these are kind of some of the points that we have experienced, and I think it's important to keep them in mind. Hopefully we don't need another pandemic, and we're not going to face another one, but just in case, to be ready, just in case something happens. Thank you.
Thank you so much. We really hope not. But meanwhile, there we have some very good ideas on moving forward. And maybe, Judy, maybe the final question for you before we move to the Q&A. Hearing all of these important things to be doing moving forward, I would like to ask you, what do you want to see governments do next when it comes to protecting and improving people's mental health and well-being during this pandemic?
Okay, thank you so much for that. I believe that the pandemic, as Bridget has put it again, it did really put mental health to light, and improving the mental health of the public is proven to lead into improved health systems in general, as well as social and economic factors in the country. And I will quote again WHO, because as a member state, we really look up to them. $1 spent in mental health care saves 5. So we have been making steps in the right direction in my country, although there are baby steps. Last year, our National Mental Health Action Plan was launched, and it outlines the interventions intended in the mental health sector in the next 5 years, which has, in the next 5 years. This has seen a bill to decriminalize suicide being pushed into law, into the hands of the lawmakers. We have also seen a redeployment of specialized primary healthcare workers into mental health services to take it to an integrated, to make sure that the services are integrated from the lowest level of healthcare. However, there is still so much that can be done, that needs to be done in service delivery, in the improvement of our mental health institutions, and also advocacy. And this will be possible and sustainable if the national budgets are allocated to the improvement of the overall service in mental health care, and also giving priority to promoting mental well-being and also the preventative measures in general. Thank you.
I couldn't unmute myself. Thanks to you. Thank you so much. We don't have a lot of time, but we have a little bit of time still to have a few questions from our audience who have been actually quite active in the chat. If there's any other question that you or dear panelists see in the chat that you could answer through a written question, please go ahead and support us. But we're talking about priorities, and there's actually a question that also asks about priorities, but priorities in terms of research. What are the priorities in research in COVID and mental health? I don't know who of you would like to answer that question. Maybe Mary, do you like to go with that?
Thank you. Yes, Carmen. Yeah, I think there are a lot of things that need further study in terms of COVID. Of course, the post-COVID condition, that's now actually studies are emerging on that. Very important topic. I think another important topic, and Mark also touched upon that, is severe psychological problems such as eating disorders, suicide, of course, because we know now only from the beginning of the pandemic, but we have to really track and monitor what will happen over time. We are not entirely sure what will happen in terms of recession. Economic recession, we know from previous economic recessions, has a lot of impact on suicide rates. So we really have to closely monitor that. So I think there's actually a lot to be studied. Also, indeed, things like problematic internet use, gaming addiction, substance use, obesity, yeah, all kinds of negative consequences. There was also an issue raised in the chat about positive consequences of the pandemic. And I think this is also a very interesting topic to study. And to be honest, we didn't find any systematic reviews or meta-analysis on that topic yet, although there were some individual primary studies published on positive consequences. But I think there needs to be much more evidence before we can really draw firm conclusions.
Thank you so much. That's extremely useful answer. And actually mentioning also another question in the chat that I think, because it touched a little bit on what Mark was mentioning before, one of our audience members talks about the social determinants of mental health, mentioning that they are complex and they're also been, those social determinants themselves have been impacted by the pandemic, as Mark was mentioning. So there's a question on reflection on comprehensive programs that can deal with this, focusing more on the social determinants than on maybe treating conditions. Do we have any pointers from our panelists on programs who could or who we know deal with the social determinants of mental health? Maybe Mark?
I think it's good to combine the discussion of social determinants with the discussion of services. Right? So if you think of poverty, violence against women, inequity, those are all very powerful. Violence against men, also violence. These are all very powerful determinants for mental health, and for mental health, and for health, and for lack of well-being. And even if they weren't harmful for mental health, we should still address these, right? And there's many agencies beyond mental health working on that, right? UNDP, development programs, all kinds of work on that. And all that work, we as mental health experts should cheerlead that and argue, saying how important that work is, because it really affects us. It affects mental health. But in services, the people, many of the people who are most likely to come to services have most suffered from those determinants. Not all, because some people come very privileged, still come in and to services, but disproportionately many people who have lived severe losses or victims of violence, etc. So the services themselves need to target better those who are most exposed to these determinants. And I think services programs do that. I think Basic Needs will do that in its work. I think organization you used to work for, Carmen, CBM, will do that in its work. So I think there is many programs that have good community with good community arms do that kind of work.
Thank you so much, Mark. I agree. I think these are very good examples of programming that doesn't have to happen necessarily only at the service provision level, but going down to the community and being able to address from the community all of the social determinants, all of the factors that affect, and then strengthen the resilience, if you'd like, of our communities. Looking at the time, I think there's a few questions that you've actually responded while you were answering the other questions or while you were presenting. There's a question on the impact on children. And I think that would adverse childhood experiences and the impact on as another one that could have a lot of time. I'm going to encourage our presenters today to share any input or any ideas in the chat for our audience. But I would like to go with one more question with all of you, same question for all of you. And you know how we like to do this Twitter-like answers. I would like to ask you for Twitter length kind of answer. I'm never too sure what that means, but I guess it's not too long. Not much of a Twitter person myself. And the question is, what must be done? And I think it kind of touches on all of those questions from our audience, from all of those different points of views and perspectives. What must be done to protect the world's mental health from pandemics? That is not an easy question, but I would like to hear from each of you. What do you think must be done to protect the world's mental health from pandemics? Although we hope, as Brigitte was saying, we might not experience another big one, but what needs to be done? Marit.
Yes, so I think, well, I'm not that good in Twitter sentences, but I'll try, I'll do my best. We need, I think in general, we need to really invest in effective interventions to be accessible for everyone in need of mental health services or services that actually address social determinants.
Wonderful. I think you would be very great at Twitter. That's a very concise one. Thank you so much. Maybe I can go over to Judy. What do you think?
I believe to protect the world's mental health, each individual would need to realize the value that we all add into people's lives when we allow people to speak up. And this way we all become the safe space that everyone is looking for. Thank you.
Wonderful. Back to our own individual capacity to recover, probably very linked to what Mark was saying, that maybe the impact is not so bad. Maybe it has a lot to do with that capacity that each of us have to overcome. So now I mentioned you, now I'll go to you, Mark. Show us your Twitter capacity.
We must apply a psychosocial lens when implementing physical distancing measures. And I have two tweets. I have another one.
Wonderful.
We must transform mental health care to make sure there's access to care.
It's worth the use two of them. I very much agree. And I thank you for those two tweets. There you go. Brigitte, over to you. What is your 2 cents?
Well, I mean, my Twitter stance is that I think we need to recognize that mental health is an integral part of health, and we need to learn from the past in order to relieve the future.
Wonderful. Those are really great tweets. Now you have to all be in social media because you've proven that you're good at this. And those are also tweets that go back to the essence, which is we all need to be more and more aware of mental health needs globally. We need to keep on prioritizing. I think we all agree, and our dear panelists were mentioning the increase on the focus on mental health since the pandemic, a kind of a positive side effect of the pandemic. But we need to make sure that it's not just pandemic related, that as Brigitte was saying, there are other crises happening at the same time, and even in non-type of crisis, mental health is so present in our lives, and is a fundamental part of our health. So no losing the focus and continue working on mental health globally. I want to really thank all of you. You've provided us with a wonderful opportunity to learn more today, to contribute to this focus on mental health that we're talking about. Thank you, Mark. Thank you, Merit. Thank you, Judith. And thank you, Brigitte, for your time today. Thank you to our audience. I would like to advertise that the next Mental Health for All webinar next month will be actually on something that relates very much with this needs to be done. It's about universal health coverage and mental health. How can we make sure that mental health is a fundamental part of universal health coverage? So you will be hearing soon how to join that webinar, and we're really hoping to see you there. And keep on taking care, keep on putting mental health at the center. And thank you for your time.
Thank you, Carmen.
Thank you.
Thank you.
Thank you. Bye.